The broadcast is now starting. All attendees are in listen-only mode.
Hello, this is Carrie Jacobson, Outreach Specialist for Center for Change. Thank you for coming and joining us today for our webinar. Attendees are welcome to submit questions in the questions pane located in the toolbar, and the presenter will try and get to a few questions at the end of the presentation. A copy of the post-test is in the handouts pane in the toolbar. Please feel free to view or print the test questions for review during the webinar. However, the test must be taken online to receive CE credit. A copy of the PowerPoint slides and other handouts are in the handouts pane. At the end of the presentation, the webinar program will ask attendees to complete an evaluation of the webinar. About an hour after the presentation ends, attendees will receive a follow-up email with instructions regarding taking the post-test and receiving a certificate of attendance. Let's go ahead and get started, and I will turn it over to Dr. Reid Robison and let him introduce himself.
Hi there, thanks for joining. We'll just jump right into it, and feel free to submit your questions. I'll try to get to as many as we can at the end. Let's see. All right, so TMS has been around for a little while, even though it's gaining more and more attention and traction in the field of mental health lately, probably because insurance companies have started to get more and more on board in recent years. And we'll go over a timeline of that. But TMS, first of all, to back up a bit, stands for Transcranial Magnetic Stimulation. It's an FDA cleared, which is kind of like FDA approved, but for devices, an FDA cleared device and therapeutic option for treatment-resistant depression, and now for OCD with that approval that just arrived last year. It's an alternative to ECT. That's kind of how it was positioned initially, but without the need for anesthesia. You can drive yourself to and from treatments, less invasive. It's basically like an MRI strength magnet aimed at a certain brain area that fires this magnet, which leads to the firing of neurons in the brain in that area, or the modulation of neurons in the brain in that area when overactive, in order to either wake up a dormant depression pathway or modulate one that's gone awry in anxiety, OCD, and, as we'll talk about at the end, eating disorder applications. So let's see. Some just little tidbits of TMS in a nutshell, so you have a feel for what it's like before we dive in deep on some of these things. It's a daily weekday treatment in an outpatient office that lasts about 20 to 30 minutes per session. You're awake, alert, no anesthesia. You can drive yourself to and from. Typically for depression, for example, 30 to 40 sessions are done 5 days a week. And if patients can't make it to a session, they just skip that day, or if they can't do 5 days a week, sometimes clinics will do protocols with a little less, and it just delays the benefits by that amount of time in some people based on typical response times. But people typically begin to see results within the first 1 or 2 weeks, and we'll talk about outcome measures and some data from studies, but it does seem to work at least as well, if not better, than typical antidepressant medications. And post-treatment on any given day, patients can go right back to their normal routine, drive themselves home. It's extremely well tolerated, a non-medication intervention, which is a large part of why it's interesting, especially to some patient populations. And there are really no long-term side effects to be aware of. I think the most common side effect would be discomfort in the head or scalp at the treatment site, usually showing up just in the first couple sessions and mild. There might be a headache for some, even less common in between sessions. The scariest side effect that you might hear about would be a risk of seizure. There have been a few on TMS in individuals at risk in general, like with a lower seizure threshold or seizure disorder. But there's never been a bad outcome from any of these events, and it is relatively uncommon. I haven't seen it in any of our TMS work. So here's what it looks like compared to medications and ECT. Response rates we'll talk about by going over some studies, but you can see a response rate in this table showing a 60-something% response, a little less than ECT, a little better than medications. Response is typically defined as a reduction in depression score by 50%, measured from, say, the beginning of the treatment course compared to the end, or at whatever point you're measuring it. Remission is getting those depression scores into a normal range. And so TMS has been given to tens of thousands of individuals. It has been around for quite a while. But as I mentioned, it's gaining more and more attention and awareness as a much needed, more durable and non-medication intervention for our clients. So to take a step back even further, where does this even fit in mental health, in psychiatry? It lands in what we'd call neuromodulation or brain stimulation technologies, which is basically focusing delivery of a modifying agent, in this case, a magnetic stimulation causing electrical signals, electrical firing in the brain. And they range from non-invasive like TMS to even surgical implantation of devices that we see in many conditions in neurology, even psychiatry, like vagal nerve stimulator, deep brain stimulator. And I have been involved in some of those studies as well in my time at the University of Utah, and those have their role, certainly. Vagal nerve stimulators you'll see more often, but even we did a deep brain stimulation study of depression, severe, intractable, treatment-resistant depression in collaboration with neurosurgery, and it can be a life-saving intervention for severe OCD, depression, and some movement disorders. But so brain stimulation in general is the delivery of electrical or magnetic fields, in this case transcranially, to a specific part of the brain. And also these could be lumped into a broader somatic type therapy bucket. So we talked about some of these types of neuromodulation. This is a little more that you can review on your own if you'd like, but I'll point out this image of a brain scan, a PET scan, in an individual with depression and without depression, showing underactivity in many areas of the brain. So the brain is thought to, based on these types of studies, thought to be somewhat dormant, especially in the deeper emotion and mood centers like the limbic structures. And in TMS, we use the dorsolateral prefrontal cortex as a gateway to those deeper mood structures. So we aim the MRI strength magnet at that area, and we fire it at a strength that's high enough to cause the firing of neurons. Then this is, in general, sub-perceptual to the individual. They hear the machine going. They might feel a little bit on their scalp, but we're training the neurons like you would be doing by playing the piano or even thinking a positive thought or mantra, but we're doing it 2,000 times each session, and then we do it 30 to 40 times, so we're talking about 100,000 firings of positive mood state neurons to reactivate, wake up those areas, and retrain them to stay awake, resulting in improved mood states. And so this is a comparison of TMS and ECT. And we talked about this a little bit, but electroconvulsive therapy, if you're not familiar with it, while technically non-invasive, takes a lot more Time off is a lot less. It isn't as well tolerated, of course, because you're basically inducing a seizure while using some anesthesia to make it safe in somewhat of a brain reboot for the individual. And while it does work faster, it's harder to access, and there's some memory issues for some surrounding it. And so it's more reserved for acutely severe depression with suicidality or some other conditions like catatonia, and now we have TMS as an option if there's that time, that 1 to 2 week leeway to get something started and start to see some improvements. This dates way back, the use of electricity in medicine, and it's interesting if you look up some of these old discoveries and stories around 15 AD, for example. They figured out how to use a torpedo fish, which is a fish with an electric organ, like an electric eel, to apply an electric charge to patients to relieve them of pain. And just some eel trivia for you here. The electric eel is found in muddy rainforest waters of South America. They have these 2 specialized organs that contain electrolytes in them, lined up end to end like a bunch of batteries, and they can send these high voltage pulses of energy, like 500 volts, sometimes used in both self-defense and hunting. And it's interesting to look at the research that's been done, and this is an aside, but they do manage to stay away from each other's electric shocks. Getting back to the human body, the average human at rest produces 100 watts of power, which is about 2,000 kcal per day of food energy, and the term kcal does reflect the energy needs. And so over a few minutes of intense activity, or more if you're a trained athlete, you can sustain several times that 100-watt level of power. And during sprints, like an Olympic athlete doing a sprint could output 1 to 2,000 watts of power. And just on the right here, to put things in context and perspective, here's a current and its effect on the body. Like 1 milliamp would be barely perceptible. 3 to 9, you'd feel pain. 9 to 20, that's when you're shocking a muscle so it contracts and stays that way at that current. 60 milliamps or more could send the heart into a weird rhythm. And at 5 amps or more, you could have tissue burning. And this does depend on some factors in the human body, like the points of contact and whether the skin is wet or dry. And so the heart is a self-powered pump that produces these action potentials of up to about 50 millivolts. And these pacemaking currents travel through the heart and trigger a series of pumping actions. And we measure this through our EKGs, or electrocardiograms, that measure about 1 millivolt. And this is all kind of resulting in action potentials, ion exchanges, coming from you may remember from cardiac or EKG training, the SA node, the sinoatrial node. And so then the brain, of course, we're getting back to the most relevant part of all this is what we're targeting in TMS. Is the brain itself generates 12 to 25 watts of electricity in a given day. There are 100,000 chemical reactions that take place in the brain every second. Neurons can connect to through these sequences of events, so up to 10,000 other neurons. And we do have 100 billion of these neurons in the human brain. Here's some more brain trivia. The average attention span of humans is shorter than a goldfish. 20 minutes for the average human. It used to be more than 30 minutes, but then we got iPhones and screen time and all that stuff. Short-term memory can only store 7 pieces of info for 20 seconds. is what you may have heard as a classic amount of information, and probably the reason behind our phone numbers being that many digits. Your brain as a computer could hold 2.5 million gigabytes or 300 years of TV shows. And interestingly, 96% of all of our decisions are subconsciously made, almost reflexively. And our neurons do travel at pretty high speed, 150 miles an hour. So looking at how the brain works from a neurochemical or neurotransmitter standpoint, we could oversimplify these main neurotransmitters like dopamine. You may already view it this way. It is where we get our joy of rewards or expectations of rewards. And the brain does habituate to this and seek this, which is why we keep seeking spikes of dopamine. Speaking of those devices we keep in our pocket that we check hundreds of times a day to see if we got a like on social media or a new message or a thumbs up, that gives us a little spike of dopamine. Or it's a reason people sit at a slot machine pulling that lever over and over, because once in a while there will be a sound and a pile of nickels falling and a spike of dopamine. And especially when this is unpredictable or variable reinforcement, it gets laid down even stronger as habits. Serotonin we view as kind of another form of pleasure, especially with social importance, place in one's community and tribe, respect, pride, and oxytocin is comfort, social trust, kind of parental, especially maternal bonds, and released with touch and safe comfort. Endorphins are what takes care of or masks our pain, or the feel-good chemicals. And so our brains seek rewards and avoid harm. And so these positive neurotransmitters, let's say, you move towards them. Some of the negative cortisol-based stress responses we move away from. And it helps to understand that when we're trying to make sense of our brains and behavior, as the brain is looking for new ways to turn on the happy chemicals or the positive ones. But when these wear off, you have this baseline state of some of the less happy chemicals like cortisol. And so it helps to keep in mind that these frustrating trade-offs are part of everyone's day-to-day life and everyone's struggle. So when you step towards new and exciting things like more dopamine, you move away from the safety of like your comfortable social bonds. And so there is the allure of dopamine, but less oxytocin, and that might feel uncomfortable. And when you step towards more social importance, you're putting yourself on the line. So you're seeking more serotonin, you might get more cortisol and stressed out state. So dopamine basically is where we find new rewards, oxytocin, social bonds, serotonin, our place in the world, and some feel-good mood states and neurochemistry tied to that. So just a little takeaway on this neurotransmitter refresher. I know it's an oversimplification, but these unhappy chemicals are part of our normal operating system, and they have a purpose. They alert us to survival threats, much in the same way that the positive, happy chemicals alert us to survival boosts and even propagate our species or help us keep searching for food and nourishment. And the unhappy chemicals connect to neurons, so you can learn about danger. When something causes you pain once, your brain keeps an eye on it, and keeps trying to avoid it. Unhappy chemicals will always be there because danger and disappointment are part of life, and your brain wants to protect you. But we need to keep in mind that we can live with these less happy mood states and even build new pathways to coexist with them. So instead of seeing them as an urgent disaster, we can use them for what they are, like a signal that protects us and helps inform us throughout our day-to-day life. And so this slide, we're getting to the foundation of TMS and how it works. Neuroplasticity. So our brains work by pathways that communicate with each other by these chemical and electrical messages. And each thought or feeling coincides with a particular pathway. And they're like roads or paths that our thoughts and feelings travel on. And the more our brains practice a certain pathway, the better it gets at doing whatever it is that we practice. Kind of like muscle memory, learning to play a sport, or learning a new dance, learning to play an instrument. But this happens in our neurons as well. And I like to think of it sometimes like grooves on a mountain bike trail. And as bikes travel on the same path, an indentation or rut is made, and then next time you or someone else travels along that path, you're more likely to slip into it. And that's kind of like how neuroplasticity works. But the beauty of the brain is that it can learn new tricks, new pathways, and especially if we take some conscious control over it or implement interventions like TMS therapy to retrain the brain when a depression pathway has kind of faded or become dormant. So to sum it up, repetition can build new pathways in the brain. When we find something that works and repeat it, a habit builds in the brain. And you'll see different numbers for this, but typically it's thought that if you do something over and over for every day for over a month, so let's say 45 days, it does become a new habit, a new pattern. So you've got to hang on in the meantime and know that these positive lasting changes do take time, and that's kind of how TMS works. It takes some patience and commitment to get to the point where there are those more lasting mood benefits. And so just a thought about why the brain gets stuck in these negative patterns or negative thought loops. And as we've been talking about, our brains evolved through the ages to both seek out positive rewards, but also scan our environment for threats. And so whatever turned on that threat chemical, like whatever brought some cortisol in the past, laid down a neural pathway that turns it on sooner for future threats. And so our brain is designed in this way to protect us from not doing something like touching a hot stove twice. And to compound this, we're born in a helpless state more than even other creatures, and we do need help. We need the social support, and from that, because we need that and turn to the social support, we get the good feeling of oxytocin. We can also end up with some serotonin in the process by banding with our tribe, and a sense of control, which brings about dopamine. So in a way, our brain chemicals in certain situations can reinforce some negative thought patterns, and you can end up seeing the world through a negative lens. So what to do about this? Well, we recognize that these frustrations, these negative patterns are electricity flowing through old pathways in the brain, and cortisol is triggered. Whoops. Let me go back here. Okay, there we are. Cortisol is triggered when a new experience fits this neural pathway, and the negative feeling will soon pass if you avoid triggering it more. So, and remember your power to build new networks. You can give your electricity a new place to flow by focusing on positive new choices, pathways, actions, and turn on dopamine by stepping towards rewarding things. Some might call this behavioral activation therapy, like taking one step initially, putting one foot in front of another, even if it's small ones, and then the neurochemicals and the positive mood states will follow. Same with TMS. Sometimes you got to get in that chair, start the course of treatment, even though it feels it may feel hopeless, it may feel frustrating for the first week while still in a overall depressed state while waiting for things to kick in. We can stimulate the nice feeling of serotonin by focusing on what we have rather than what we lack. Stress chemicals like cortisol alert us to avoid obstacles in survival. So back to TMS. TMS, as I mentioned, produces this MRI strength electromagnetic field and enough energy to create an action potential, which is basically the firing of neurons. And this is like a domino effect, because one neuron fires another, and this pathway of neurons gets deeper in the brain, like the limbic system. So when you wake up the limbic system or light up this pathway, that's associated with more positive mood states. And this is where TMS shines. When a singular thought, positive thought or practice occurs, that pathway is fired once, but a single session of TMS stimulates that pathway 2,000 times, and you do a course of 30 to 45 sessions, you're getting up there towards 100,000 times. It's like flexing that muscle or practicing that instrument 100,000 times. And practice makes perfect. Neurons that fire together wire together. And so who shouldn't get TMS? When you have a metal plate, this is because it's a magnet, just like getting an MRI, there could be issues with a metal plate or a stent. If it's an ear piercing, you can just remove it to be safe. If it's one small nose piercing, like a stud, that's fine. And if it's, but when in doubt, if it's a metal anywhere above the shoulders, we need to take a close look at whether or not that's safe. And so we'll talk about depression for a moment. Here's that image again, PET scan of a brain in a depressed state and when not depressed. And one of the big problems with depression, besides that it's just so common, is that we don't have great tools to treat it. And it's being understood more and more to be one of the leading causes of disability worldwide. The impact on our lives and the lives of our loved ones is huge. The impact of lost work, the impact of lost lives makes this an urgent problem to work together on addressing. And 1 in 6 people will have a major depressive episode in their lifetime, and suicide rates continue to climb. The problem is our tools just don't work that well. Medication responses might be 30 to 40% per medicine. After a trial of 2 or 3, you can get up to 50, 60%, but there are also side effects in many of these medications for many individuals. So here's what TMS looks like in a clinical trial setting. The bottom line is 1 in 3 of these individuals who were resistant to medications, like those who have tried and failed medications, 1 in 3 achieved remission after 4 weeks, which is huge. It doesn't work for everyone, but remember, remission is getting depression scores down into the normal range. It's not just response. Response is reducing those by, say, 50%. And when they do these studies, it is a placebo-controlled trial, a double-blind study as well. And instead of a sugar pill or placebo pill that looks like a regular pill, in a device study, it's the same device, turns on and makes noise but doesn't fire the magnet. They call it a sham, if you see that term. And so this is what it looked like in real-world settings, and this is approved by the FDA for treatment-resistant depression. So in order to get insurance coverage, typically we need 3 or 4 failed trials of medications, often in the current episode. But this is what those studies look like over a course of 30 sessions. 1 in 2 achieve full remission. 1,000, they looked at 21 centers, 1,000 patients who got 20 sessions, 700 who received 30. And this is what a course looks like. TMS session is about 20 minutes, typically a 30-minute appointment. Depends on which device and how the center likes to set these up. It's going to be 5 days a week, ideally for the first 4 weeks or so, and then we will typically step down the frequency from there, whether it's 2 or 3 times a week for the next little while, basically tapering off for a smooth transition into not having TMS. And if depression symptoms do return, or if they remain but did benefit from a course of TMS, we can and often do ask the insurance company to provide us with more sessions for another course or maintenance. And we talked about the advantages of this being a non-medication therapy. It's not, it's not a one-size-fits-all universal fix or a magic solution by any means, but it is an exciting non-medication intervention in this new era of more of an interventional psychiatry, going into an office for things other than getting a refill of a daily pill with the side effects that go along with that. And this is often used in combination with medications and in combination with psychotherapy. So last year, TMS was approved or cleared by the FDA for obsessive compulsive disorder. And this, insurance companies are still dragging their feet a little bit, getting on board slowly, which is typical with a new treatment modality. So I expect that will get easier and easier as time goes on, as more studies come out. But as evidenced by the FDA clearance, there are positive studies out there showing this as an important potential tool for individuals with OCD, especially those who are treatment resistant. OCD is especially hard to treat. It takes years, often a decade or decade and a half, to even get treatment for some individuals. And this figure in the middle here is striking to me as well. 85% endure serious or moderate impairments due to their OCD symptoms. So this is a condition that certainly does interfere with the individual's life, as does depression. And there are only 5 meds FDA approved to treat OCD. And these, similar to antidepressants, just show maybe a 30% improvement in symptom severity for 40 to 60% of individuals. And so that leaves a lot of people in need of additional help beyond what medications and therapy have been able to address. And here are those meds for OCD: Prozac, Paxil, Zoloft, fluvoxamine, and clomipramine, a tricyclic antidepressant. And this is where the OCD treatments in TMS are focused. Instead of the dorsolateral prefrontal cortex like TMS for depression, OCD treatments are aimed at the anterior cingulate cortex. And what's also interesting to note, and we'll talk about this on an upcoming slide, is the treatment is done after a provocation script. So what we'll do, and let me see if I can get to this slide. TMS is thought to be more effective when this circuit or pathway we're targeting is active, whether that be thinking about or even acting on obsessions, compulsions, phobias, to get that part of the brain active, and then we start the course of treatment right then, fire the TMS magnetic field and modulate it while it's in full gear. And so we'll often rank obsessions, compulsions, for example, and pick one that's reasonable to access in a clinic setting, like say a fear of germs. You might imagine touching a doorknob. I know that's an interesting one these days with what's going on in the world, and all of our infectious disease worries. But in OCD, there's this rumination and inability to stop or get out of that thought loop. And if we trigger that, then we can address it more. Kind of like in a therapy room, and doing, whether it's group or individual therapy, working with triggers and working in the here and now is where we get our best results. So let's see how we're doing on time. Not bad. So I'm going to back up here on some more OCD, background. So here's what a brain scan looks like in OCD, comparing healthy volunteers versus individuals with obsessive compulsive disorder. And this is what one of the studies pointing to the anterior cingulate cortex, where the greatest differences in those groups were observed. So there are areas of hyperactive thought loops and areas of underactive inhibitory control, like the inability to stop from, say, hand washing. So here's just a summary of some brain behavior considerations in OCD. OCD comes with the impaired ability to inhibit intrusive thoughts, feelings, behaviors, inappropriate automatic and subconscious threat responses, or ones that are sustained inappropriately, decreased ability to stop or correct behavior, to learn and adapt and extinguish these fears and habits, and getting stuck in these loops of obsessions in search of reward or some of those other brain chemicals we talked about. And then lastly, dysregulated evaluation of punishment over reward. And this, a lot of this applies to our clients with anorexia nervosa as well, and we'll talk about that. And that's one of the reasons why I view TMS as a really exciting potential therapeutic strategy for individuals with eating disorders, not just for the comorbid depression, anxiety, but also for the core symptoms of, say, anorexia that runs often along with OCD or overlaps with OCD and some of the neurocircuitry and what's going on in the brain. Here's what OCD looks like in a clinical trial setting. The standard for measuring OCD symptom severity is a scale called the Y-box, Yale-Brown Obsessive Compulsive, whatever the S stands for, scale or severity. But you can look that up. It's freely available. I use it all the time in clinical settings to get a feel for how we're doing, whether it's with the medication therapy or TMS, or even just to get a sense for how this might play a role in related conditions like anorexia. And so on the top here, response rate shows 38% of patients responded. Over 50% at least partially responded. And this was, again, among individuals who had tried and failed meds and therapy, like SSRIs. And if you're familiar with the Y-box or do try it out, you'll get a total score by taking that. And these studies did show a significant reduction in Y-box score after 6 weeks, or over the course of 6 weeks. You can see it ramping up especially from weeks 2 to 3, 4, and as we get to that 6-week point where the vast majority of the benefit was attained. And here's another study, 11 centers, almost 100 patients with at least moderate OCD on meds and therapy. They looked again at the Y-box, and the response was defined, as it is in some studies, a reduction in the Y-box score of 30% defined response. And here's that 38% response rate, 54% partial response, and a very low dropout rate of 10% or less. And again, this is especially impressive when we remember these are individuals who didn't respond to meds and therapy. And here's what it looks like from a different perspective, just showing symptom improvement after the first 1 or 2 weeks compared to placebo. And the same protocol principles apply, where the treatment is a little bit longer of a session because of that provocation script, and there's a little bit more prep work and evaluation to do at the beginning because of that. But you know, that's useful for a number of therapeutic strategies to really get concrete about the individual struggle, obsessions, compulsions, and to create somewhat of a hierarchy and priority of which ones are most distressing. And so that leads us into the last part of our discussion, which is why consider TMS for eating disorders, or what lies ahead for the use of TMS in beyond depression and OCD. So right now we can and do use TMS for individuals with eating disorders where there is also major depressive disorder that's treatment resistant, for example, or where there's also OCD. In those cases, especially for MDD, insurance companies, most of them have policies that say when they will cover TMS, and most insurance companies will cover TMS under those circumstances. But beyond that, some of these, some research groups and some of the TMS device manufacturers are doing studies of TMS for a variety of conditions within this within the eating disorder field, like anorexia nervosa. And just looking at how anorexia impacts the brain, over numerous studies, we're starting to get a feel for the impact anorexia has on the striatal, frontal, and limbic brain pathways, leading to issues with emotional dysregulation, habit, reward, and reinforcement pathways. And as we encounter so much clinically, a lack of cognitive flexibility, inability to see the forest from the trees or allow oneself to eat or relax one's dietary rules, for example. So the prefrontal cortex is also a highly notable one correlated with eating disorders, because when it's underactive, there can be less impulse control, like we talked about with the brain behavior findings in OCD. And so restoring balance to this and other areas does show promise theoretically for treating eating disorders. And there are a number of studies to add strength to that. For example, this is one that they called the Tiara study. And I have a summary of this. This is a reference here, but a summary of this is on the next slide. It included 17 people per group, TMS and placebo, or also known as sham. They looked at BMI, mood, eating disorder symptoms, quality of life over 20 treatment sessions, 1 month period, and they targeted the left dorsolateral prefrontal cortex, which is the place we target in depression treatments. And there was significantly improved mood and quality of life. Even BMI got better, and eating disorder scores got a little better with this treatment protocol. This is a group out of Toronto, and I was just talking to them about this study they did, looking at, it was more of a pilot study, looking at deep TMS, where the device is made by a company called Brainsway. And the same device we use here at Center for Change and Cedar Psychiatry is the Brainsway device. And they're the only ones who have the FDA cleared OCD part of the device for OCD treatments. And they also found reduction in anorexia-related obsessions, compulsions after this deep TMS, along with reduction in depression and anxiety scores. Because as we know clinically, depression and anxiety are very tied into the core symptoms of anorexia as well. So this is a small pilot study, but it does suggest that TMS is safe and well tolerated and may be of benefit for anorexia, even severe anorexia. That was their study population. But more studies, of course, are needed, especially large-scale, blinded, sham-controlled trials. There are some case reports and beyond to support both binge eating and bulimia being improved by TMS. And here's a reference on the binge eating, for example. There's a review of the literature reference here that you can check out for more information. And then this study was one where they took 28 subjects with anorexia binge purge subtype or bulimia, and they got 20 to 30 sessions of TMS. And by the way, these studies do often collect MRI data, but an MRI is not part of the typical protocol for initiating TMS. And we can talk about that in the questions of how we find the brain area before starting treatment. But we typically will use some measurements to find first the motor strip in the brain, and then start at a low intensity and increase it in single individual pulses until we trigger the movement of, say, the fingertips of one hand by this electromagnetic device. One pulse of the device make the fingers ever so slightly twitch. We know we've got a high enough intensity to fire neurons. So then we move it according to a database of many people's measurements of where the dorsolateral prefrontal cortex is with respect to the motor strip. We then aim the device there and we start the treatments little below threshold the first day, increase it, and we're getting above that threshold that barely makes the fingers twitch, and we carry on with the sessions there for the remainder of the course. And so this study, 16 of the 28 responded to TMS, and they had and they get into some of the brain imaging correlates of this to help better understand it. So a very interesting one if you want to dive in deeper on what's going on in the brain. And this is a summary of TMS studies for eating disorders, but I won't get into that. For those of you who would like, you can check out the slides that have or will be sent around, and this as a reference. The last thing I'll point out before we move to questions are some of the other uses off-label and being studied for TMS. So the top line is depression, and a typical protocol for treating depression, and this is on label, FDA cleared, covered by many insurance companies, aimed at the left prefrontal cortex. Bipolar depression, while not technically covered by insurance or FDA cleared, there's some evidence to support using TMS for depressive episodes in bipolar. There's some studies on the negative symptoms of schizophrenia. I was involved in some of those back a decade ago, looking at both individuals with schizophrenia and healthy normal controls, and what TMS can do to improve reaction time and some other neurocognitive measures. And TMS is used in some clinics or centers for brain training, even in, that's not a clinical application or insurance covered indication, but it does have some interesting potential there. Here's a protocol for migraines. TMS is being studied for PTSD, generalized anxiety. We do anxiety treatments a lot via TMS, and sometimes we can add those onto a depression one in the same day, or someone can come in and for an off-label treatment. The next indication that I would guess might be FDA cleared for TMS would be smoking cessation, maybe PTSD after that. So with that, I will end the presentation and move into questions. So, Okay. The first one. This is just asking if there will be a copy of the slides or the articles. I think it's about the articles emailed to us. So I believe the slides were provided. If not, reach out to us, the contact info from where you registered. The answer to that question is if you want any of the references that were mentioned in the slide, please reach out to me if you don't have my contact info. The easiest one to share with you is Reid, R-E-I-D, at cedarpsychiatry.com, and happy to provide any of these full text articles. So let's look, next questions. How long sobriety is recommended prior to starting TMS for patients with MDD and substance use disorder? That's an interesting question. So as we saw in the last slide, TMS is looking promising for some addictive processes and behaviors like even smoking cessation. And substance abuse runs commonly along with depression and some of these other conditions. I'd say there isn't a period of sobriety needed, but there is something to be said about open communication and consistency, but open communication with the treatment team, because at the beginning of TMS, we find the threshold, the motor threshold, we call it. What intensity of the magnet firing leads to firing of neurons in a given individual. And this is also related to seizure threshold, that rare kind of theoretical risk and somewhat of a real world risk in TMS treatment of having a seizure depends on your seizure threshold. And if you are on alcohol at the time, your seizure threshold is higher, meaning you're less likely to have a seizure. But if you're in alcohol withdrawal, you're more likely to have a seizure. If you're on Wellbutrin, your seizure threshold is lowered and you're more at risk. Caffeine, sleep, things like that play a role in your seizure threshold. So those we ask at the beginning of each TMS treatment and at the beginning of the course. But you can proceed in TMS without any set time of sobriety needed, but we just need to be aware of the factors at play. So any studies being used, this is the next question, any studies being used with a reduced frequency of treatments, like once a week versus 5 times a week? The way I see it, yeah, there is some data to support that. And the way I approach it is 5 days a week is best, 4 is better than 2. What it means, practically speaking, is that we're just delaying the time to response and then remission in those who will find benefit. If we space it out too much, the benefits just, the brain and its window of neuroplasticity kind of snaps back into place. What that looks like is probably somewhere in the 2 to 4 time a week time frame. But interestingly, there are these other protocols that some people do on the flip side, where if a client can't make that happen every day, or they're from out of town and don't have TMS accessible in their area, some people are doing multiple sessions a day over, say, a long weekend or a few day period, doing TMS every couple hours. That can be a big commitment of time and energy over the short amount of time, but that is an interesting one that I've been keeping an eye on, that some people use. And let's see, next question. Is it approved for use in adolescents? Good question. It is not. The FDA clearance is only for adults, both the depression and the OCD approvals. So we do it here at Center for Change and Cedar Psychiatry, but that would be off-label and non-insurance covered, and therefore out-of-pocket payment for that. And just to just to talk a little more about that, because I see some questions about insurance and level of care. The way we do it here at Center for Change is we have a partnership set up with the center and my outpatient clinic, which is adjacent to the center here, called Cedar Psychiatry, where we do the treatments there, but we do offer it to individuals who are in 24-hour care, mostly on the RTC unit and in PHP IOP. And it is, we have had lots of success getting insurance on board, even when individuals are in a residential level of care, for example, because the symptom severity is there, the need for intense treatment is there. Let's see, a couple more questions. Is TMS widely available? I'd say yes. Every state, most cities that are even 50 to 100,000 people or more are going to have a TMS device, but we're going to see it more and more. It's a paradigm shift in psychiatry to have this interventional approach, have in-office treatments, but it's coming more and more. I like to call it even an era of interventional psychiatry that we've entered, because last year we also got approval to use Spravato, S-ketamine, as a nasal spray that has to be given in office for treatment-resistant depression. So when I'm seeing an individual for depression that hasn't responded to other meds, there are multiple options to consider. There are some medication approvals for that and strategies for that. And there are these in-office treatments like TMS as a non-medication intervention, Spravato, ketamine as one-time or non-daily pill options. Okay, let's see, one more. Where can a person receive TMS treatments, or where can we refer our patients or clients? I gave my email. I'll give it once more. CedarPsychiatry.com has the most info on TMS. Center for Change website also lists it and links out to Cedar. My email, Reid, R-E-I-D, at CedarPsychiatry.com, or reaching out to us however you normally would. Ask about TMS, and we're happy to chat and see if it's right for your client or whoever you're considering it for. But I appreciate you joining in and talking about this exciting new non-medication strategy we have for depression, now OCD, and happy to stay in touch and communicate about any questions we didn't get to or as things progress. Thanks for your time.
Thank you so much, Dr. Robison. Just a reminder, please fill out the evaluation and to watch for the follow-up email and instructions regarding taking the post-test and receiving a certificate of attendance. The webinar recording and handouts will be available on our website soon. Thank you all for joining us today.